Hello, good afternoon, everybody, and happy MMN Awareness Month. I just love the month of February because this gives us a great opportunity to celebrate ourselves as an MMN patient community, raise awareness about MMN, and more importantly, what we're going to do today is dialogue with an expert on MMN and have the opportunity to take some time out and again hear from one of the experts in the field, answer some questions, and really talk about pertinent topics related to multifocal motor neuropathy. So it's my great pleasure to be the moderator of this speaker series with Dr. Chafic Karam, professor of neurology at the University of Pennsylvania, right here in Philadelphia in the foundation's backyard. Dr. Karam is also a member of the foundation's Global Medical Advisory Board and a dear friend and great supporter of the foundation. I think a lot of people on this call today will have the opportunity of seeing Dr. Karam at some of our events, and we appreciate and thank him for all that he does for the foundation and the patient community, and thank him for his time today. So before we get in, just a few pieces of housekeeping. First, I want to give a big shout out and a big thank you to our two sponsors for MMN Awareness Month, argenx and Takeda, and you can see their logos on the slide there. So thank you to both of them. And the topic for today is going to be a little bit wide-ranging with respect to MMN. We're going to go through some questions on diagnosis and treatment, different treatment options that are on the market today and available to patients. We'll also talk about research and kind of future directions that MMN treatment is going in. And then some other topics like mental health, quality of life, and we do want to hear from you, of course. And we will have the opportunity for folks to ask questions. I ask that people put their questions into the chat function so we can get those queued up and then give you the opportunity to join live to ask those questions. So that's how things will work today. And with that said, I think we can go ahead and get started here. So first, Dr. Karam, I want to give you a warm welcome and thank you again for joining us today.
Yeah, thank you, Richard, for having me. Always a pleasure. Thank you for the
Great.
kind words.
Of course, of course. So let's dive right in. Have a lot of questions to get through today that have come in from folks in the MMN community. And as I said, we'll first start with diagnosis and treatment. And I want to talk a little bit about the diagnosis process. And MMN can take very long to diagnose. I experienced that myself as a patient. Can you just kind of explain from your perspective why it is such a hard condition to diagnose, and really throughout that diagnosis journey, how can patients push for answers sooner while at the same time kind of respecting the process and structure of the healthcare systems?
Yeah, that's a great question, Richard. And I know that you've been through a long process that is kind of very emotional to get to the correct diagnosis. So a few things. MMN is a rare condition, so people as humans, and that's the right thing to do. We think about more common conditions first, right? Uh, but then that's why we have the laboratory testing to help us determine if that initial diagnosis is correct or not. So if something doesn't fit, if you do your EMG, nerve conduction study, and so forth, and your clinical exam, something doesn't fit, then it's always good to revisit the diagnosis. So that's very important. The second thing to keep in mind is that it is a treatable condition. And we know that the earlier you start treatment, the better the outcome. If you wait for the atrophy to set in, et cetera, then it becomes a little bit more challenging. So keeping that in mind, the fact that it's a rare condition that people don't think about it a lot is probably a reason why the diagnosis is incorrect. And two, I think that the fact that there's no specific test that tells you, aha, this is what we're dealing with, is another issue. Now, if you think about it and send the GM1 antibodies and these come back positive, that can be a little bit helpful to hopefully, say, I have a light bulb in your head, say, maybe I'm dealing with MMN. But one, it's not always positive in MMN. So that's something that we know. And two, Sometimes they don't check it. And then number three, we rely heavily on the nerve conduction study. And one thing that we rely on heavily is finding the conduction block. And to
Hmm.
find the conduction block in MMN, you really have to go look for it. You cannot just do your routine testing and say, oh, there's no conduction block, let's forget about it. You sometimes have to stimulate different areas of the nerve. And sometimes even there's no conduction block, but you still suspect it, you know. So, and then that's where the treatment comes in because you can do a treatment trial and can be helpful. So even if you don't find the conduction block, but you have high suspicion based on specific things that we can discuss later if you want, you know, it's good to do a treatment trial. That's what I always tell, you know, my patients and our trainees.
And the question of the treatment trial, I think, is a really interesting one. And do you think that's something that patients should push for as they're going through that diagnosis journey, and really ask their provider for treatment of IVIG to rule out other conditions?
Yeah, I mean, as you know, we are our best, meaning we, meaning the patient, because I'm also a patient sometimes.
Right.
And I've pushed for things in the medical field, not to be able to try to look smart or anything, but something that I know that really could lead. So I do suggest to my physician, like, why don't you think I should look for this? Because I have a family history of that, for example, or, you know, I'm not fitting all the criteria, or, you know, I know that this is your diagnosis, but let's explore something else and potentially try treatment. And, you know, I tell people the treatment is not forever. So if you want to do a treatment trial, not the treatment for MMN, unfortunately, most of the
Yeah.
time it's forever. But the treatment trial, so let's say you have a question about the diagnosis, you're not really certain about the diagnosis. There's nothing wrong in saying, let's do a 3 months treatment because most people with MMN will respond to IVIG. So keep that in mind. If they don't respond, then hey, you have to revisit the diagnosis. But I think
Yeah.
it's very fair to do a 3 months treatment trial in case you suspect the condition. And then if there's no improvement, then it is what it is. Now, here we have to put very strict criteria how we define improvement. And that has been defined actually by the by the experts. So there's improvement on the grip strength, improvement on the muscle testing, the confrontation that the physician will do, improvement in the function. So we can do a patient-reported outcome, for example, with the iRods that is modified for the MMN. So we predefine what is a success of treatment is, not just, oh, I feel better or I feel worse, because these are very subjective. But if you
Yeah.
have gain in function, if you have gain on your grip strengths, if you have gain on your muscle testing, then that would push you in the right direction for treatment and continue and the diagnosis. And then one last thing that even in the criteria for MMN that were written, you know, more than a decade ago, treatment success is one of the supportive criteria. So if you have objective response to treatment, you can check that as potentially supportive of the MMN treatment.
No, that's super helpful, and thank you for that explanation around the concept of a treatment trial. And just kind of sticking with the theme of diagnosis and differentiation with other conditions, aside from the nerve conduction block, and certainly feel free to go deeper there. How else do you clearly differentiate MMN from other conditions like ALS or even CIDP?
Yeah, that's a great question. So obviously ALS is the big elephant in the room because elephant can kill you. Yeah, ALS can kill you. MMN does not. So and MMN is treatable. ALS, unfortunately, is not treatable today unless you have a very rare genetic form, by the way. So ALS, what is about ALS is that it's a combination of what we call upper motor neuron signs, which means that the brain and the spinal cord are involved. And then when you examine the patient, you may have brisk reflexes or you may have an upgoing toe. So these are signs that the clinician will look for to say, well, this is not just a pure uh, lower motor neuron, if you want. And I'm sorry if I'm being too, scientific, but we
No,
differentiate
this is great.
problems coming from the brain and the spine we call them, these are central nervous system issue versus the peripheral nerve. So once the nerve
Mm.
leaves the spine, and the disorders that affect these areas of the nerve, the system are different. So in an MMN, the brain and the spine should not be involved. It's really once the nerve that exits. So that is a very important thing. The other thing about, but then there's a lot of things that overlaps with ALS. So the atrophy, you can see it in
Yeah.
both, the muscle twitching, you can see it in both. The finding on the nerve conduction study, even the EMG, can be very similar. So I tell my fellows and resident, if you have just the pure lower motor neuron, so you have something, you think that it's an atypical form of ALS. So let's say we call it progressive muscular atrophy. But you always have to do a treatment trial. Even if you don't find the conduction block, I still do a treatment trial with IVIG for 3 months to see if there's a response. So that's number one. CIDP is a different thing. The implications are not that major because the treatment, most people in CIDP in the United States, at least, they get treated with IVIG. So the treatment will work on both conditions.
Hmm.
Know that steroids may make MMN worse. So that's something but it does make
Mm.
CIDP better. So you want to avoid that. But if you look at CIDP itself, there's different types of CIDP, but most of them affect the sensory nervous system as well. So people do have significant numbness, tingling, sometimes they even have pain. And when you do the nerve conduction study, the sensory aspect of the nerve is affected as well. So let's go
Okay.
back to the nerve itself. It has both motor, which, it sends a signal from your brain to let's close my hand. That's a motor signal. And then the sensation. So if you're open the water and it's hot, you can feel that it's hot and you don't burn yourself. So in CIDP, most of the forms of CIDP have sensory involvement, apart from one. It's called motor CIDP. And that's
Hmm.
can look like MMN because only the motor nerves are involved. But the difference is that MMN is more of a multifocal condition. So people start having symptoms in one hand, then the other, then the foot, whereas the motor form of CIDP, they have generalized weakness. So both the proximal muscle, the shoulder muscle, their elbow muscles, their hands are weak. At the same time, the legs are weak, and it's relatively symmetric, meaning both are affected
Yeah.
at the same point. So these are really the major differences between motor CIDP and MMN. CIDP itself, most of it has sensory symptoms, so that can be differentiated easily from MMN. And then ALS, the typical ALS have upper motor neuron syndrome symptoms, which we find on our examination, and signs which we find on our examination, whereas MMN does not have upper motor neuron signs.
Okay. No, thank you for those clarifying points between the different conditions. And a few minutes ago, you talked about the test for anti-GM1 antibodies. Can you just talk for a couple of minutes about what exactly are those antibodies and why that test is useful?
Yeah. So first, something that's very important, anybody you diagnose with CIDP or MMN, you have to do what we call SPEP immunofixation. So this is serum protein electrophoresis, looking for an abnormal protein in the blood, okay?
Hmm.
And the reason is that it does have implication. Now, if you have IgM, and you have a multifocal motor neuropathy, you can send for GM1. But it's important to keep in mind that these are basically, if you find the monoclonal gammopathy, like an IgM or IgG or IgA, it's very important to see a hematologist because this could be a pre-malignant state. So anybody who have those antibody should be seen by a hematologist and followed up, depending on what their recommendations are. So in MMN, there's, a lot of the patient have IgM antibody, and part of the IgM is a GM1. So IgM is the big class, and if you want to subtype it, it can be positive for GM1. And that can support the diagnosis of MMN. It's found in about 50% of the time. So not finding it does not rule out the diagnosis.
Yeah.
But finding it also, you should not be completely focused on it. You have to take the whole clinical picture because some people with ALS may have GM1 antibody, or some people with CIDP may have GM1 antibody. So it's not very specific. There can be false positive and false negative, like anything, any test that you do. but it can point you in the right direction in the correct clinical context.
Okay, thank you. And then kind of last question on diagnosis before we move to treatment, and we have a few questions coming in from the audience here. Where are we with respect to the identification of potential biomarkers for MMN that would make this complex diagnostic journey hopefully easier for both clinicians and patients?
Yeah, I mean that's the holy grail for MMN. Unfortunately, at this time, we're still relying a lot on the clinical findings, the clinical exam, and the nerve conduction study, and ruling out other condition that could mimic. So we don't really have, unfortunately, anything at this time. Still a combination of, hey, how the patient presented, what did you find on your exam, what did you find on the nerve conduction study, what did you find on the blood testing, and did the patient respond to treatment or not? So unfortunately, it's still a combination of things that we look for, and there's no kind of magic test that we can do. Hopefully, we'll have something more specific in the future. The good thing is that there's a lot of interest from pharmaceutical company,
Yeah.
and when that happens, they could look at when they have large number of patients, they could look at biomarkers and try to find something that could be more specific and sensitive for this condition.
Yeah. Okay. So not holding my breath on biomarkers, but I certainly remain very hopeful. And just transitioning to treatment options and kind of ongoing treatment and management of MMN. I kind of have one high level question, and then I'll get to the audience. IVIG being the gold standard, or the standard of care rather. What are realistic expectations for MMN patients in terms of how MMN can help us and improve our lives?
Yeah, you're right. So IVIG, unfortunately, is the only options we have for MMN at this time. So,
Yeah.
and that can tell you, if somebody cannot tolerate IVIG or it's contraindicated, which sometimes happen, then you're really in a tough spot. But the good thing that most people tolerate IVIG okay, and then sometimes you have to pre-medicate them with, acetaminophen and anti-allergy medication, and that can help lessen the symptoms.
Hmm.
So IVIG, the good thing about it is that it does work. Um, and it does improve patient function and strength. So again, if people don't improve with IVIG, you really have to revisit the diagnosis and make sure you have the correct diagnosis. The other thing is that the earlier you start treatment, I mentioned that, when we first start talking, the better is going to be the outcome. If you wait, 5 years, 10 years, and I've seen, by the way, I have a patient who we've seen her 40 years after she started having problems. The
Wow.
response is not going to be as good as somebody who just started having symptoms 6 months ago, for example. Okay, so starting the treatment early is very good. I have a high expectation of IVIG. If I don't see significant improvement objectively, I'm gonna question my diagnosis. And three, it's going to be very challenging for me when I see a patient who cannot tolerate IVIG or who has a contraindication. Then we're going to go to things that are off-label and not completely proven to work.
Yep. Okay. Thank you. And I do want to now open it up to a few members of the audience today who have some questions around treatment. The first one that's come up is Eric Luno, or if I'm pronouncing that correctly. And Eric, I think you should be able to join us.
Yeah, I just got the little audio icon, so I guess now my
Great.
microphone is enabled. Yes, you pronounced my name correctly. Uh,
Okay.
I asked that question because I'm thinking about getting back on IVIG, and I want to have some sort of measure or metric and see if it's working. And most of my symptoms, I'm having some dexterity problems. I'm seeing again, and all along, a lot of my symptoms have really been slow weakness. And when I start IVIG again, I want to have some measure, like a dynamometer and grip strength, or measure my bicep, or measure my tricep, or other muscles. And I have a dynamometer, but I'm not sure how I can like measure my tricep strength. I mean, looked at different devices, and certainly other people must have a questions like that. If they have foot drop, they probably want to know if their muscles in their feet or legs are going. So, are there other devices that are affordable? I mean, I saw some things on Amazon, but they wanted like $500 for them, and it's kind of outrageous. Okay.
Well, it's great that you're trying to objectively understand if things are improving. So that's, first of all, kudos for that. Two, the handheld dynamometer is a very good tool, but it really only check your grip strengths. And it can be challenging really if somebody has arthritis or hand issues that are not related to MMN, then it's gonna be hard to pull. But that's a very good tool actually, and some clinical trial, this is really the primary endpoint is the grip strengths. Regarding other muscle groups, there's the cheapest way, what people report is that when they go, let's say they go to the gym or they try to carry something and they know that, well, I can, carry 5 pounds, curl biceps 5 pounds, or, something of that sort, or now I can do 50 pounds. Well, 50 pounds is too much. I think only Richard can do that. But, let's do something more is like 20 pounds. And then, without treatment, they go down to 10 pounds and then they go back on treatment and they're able to do the 20 pounds. So that's something that, obviously you don't have to pay anything for that. You can just choose anything that you have laying at home that is of significant weight and see if you can carry it, more frequently after treatment or not. Now, for specific devices, if you're trying to be like extremely accurate and see how much power generation you can do, this, it does become a little bit more expensive because these are typically used for research. So there are handheld devices that we can put and push and see how much power you're generating, give us typically a digital reading. And some physical therapies can help those. So one thing that you could consider is saying to your doctor, refer me to physical therapy, please, and then have a physical therapist who do this. They usually have these tools and they can objectively measure the power you're generating. And you can this way have something that is, more reliable because you have an expert who's measuring it, and to hopefully it would not be expensive for you and you don't have to buy the devices.
Okay, thank
No, I think that's the advice on physical therapy and having an expert help measure that. I think that's great advice, Dr. Karam. And keeping with the questions coming in from the audience, Martin Smith, we'll give the floor to you.
Okay, am I unmuted now?
Yeah, we can hear you.
Okay, cool. Cool. Just on the previous person, I would bear out what the doctor said is that generally I know where the weaknesses is very specific muscles, and I can always tell when I'm starting to degrade. Just with things around the house, holding a pan upright in one arm, with my right wrist, it will drop foot. It's so easy to recognize. I don't need anything expensive. I know when it's happening. But I have been very lucky. I respond very well to Polygram, to IVIG. I have it every 4 weeks, a gram per kilo. And I would say I'm lucky that in as much as I can pretty much live my life almost normally, which is fantastic. But I've been treated for 5 years. The last 2 years, every month, every 4 weeks. Prior to that, my previous neurologist let me kind of wait until I was relapsing really badly, and then he was treating me for CIDP, going back to what the doctor said about diagnosis and stuff. And I found out for myself I had MMN. Anyway, a very good friend of mine who's a nephrologist in London suggested to me that there is some evidence that regular treatment, keeping it under control and very regular treatment, does have a calming effect. And I just want to ask the doctor if there's any evidence to back that up. Because I've now had, like I say, I've had very regular treatment now for nearly 2 years and I respond so well to it. And I like to sort of say to my neurologist, maybe we should go bi-monthly. I don't want to risk relapse because there's always a risk of damage, some permanent damage each time you relapse. And I do have some permanent numbness, I think, in my feet now. But is there any evidence to suggest that the longer you have treatment, you keep it under control, that there is a calming effect, or is that rubbish? Is that, it's not really going to change? You have MMN and it's not going to change until there's a cure, perhaps.
Okay, Martin, if I understand your question completely or correctly, it's that when you're getting the IVIG, you're benefiting a lot, but you're not getting the treatment right when you're supposed to. You're waiting until you crash to get the next dose. Is that correct?
Apologies. Yeah, apologies. That was my previous neurologist who was treating me for CIDP and just waited till I complained. My current neurologist was like, no, you have MMN. It's every month, minimum it's 1 gram per kilo. We started with 2 grams per kilo the first 2 months, got me under control, and then every month religiously now for it'll be 2 years in June. And I respond so well to it that I feel like that maybe it's not an intrusion, losing 24 hours of IVIG to get your life back, once a month. But I'm wondering whether, I could drop it to 6 weeks or even 2 months. And a friend of mine warned against that and said, no, she said regular treatment. There is, it's keeping it under control, and B, there is some suggestion that it could calm down the invasive part of the immune system that is causing it. Is that true, or is that rubbish?
Yeah. So if you look at the data for the half-life of IVIG, the suggestion is that the half-life is going to vary obviously from one person to another, but on average it's about 3 weeks. So the reason we dose it every 4 weeks is really more for convenience rather than this is really the scientific things to do. I think everybody would probably start at 3 weeks, and then depending on how patient responds, I have seen people go on a little bit longer without decline, and I've seen some other patients needing every 2 weeks or even every week of infusion. So I understand that it is a taxing, it does take a long time to do the infusions, and hopefully in the future we'll have alternative options that are quicker. And I agree with you that if you want to try going for 5 weeks or 6 weeks and see if your body tolerates it, I don't think that's unreasonable request. You can try it, and if it doesn't work, you can go back to the every 4 weeks. In regarding to controlling the immune system and calming down if you want this inflammation, this is exactly what the IVIG is doing. It is kind of controlling your disease, controlling your immune system, helping degrade these, bad antibodies that are attacking the nerves. And this is how the disease is controlled. I hope that I've answered your question. If not, please clarify a little bit more.
No, that's fine. And one other thing on treatment, sorry, I don't want to hog this, but have you personally seen any evidence that a drug like rituximab is effective with MMN? I know it has been used. I've seen information where it's been used, tried with CIDP. But have you seen any data around it being used for something like MMN?
Yeah, it's not definite. People have tried to do clinical trials in rituximab, and unfortunately, they were not very optimistic. So that's why it's not currently the standard of care. That being said, I have seen patients respond to rituximab. And I've seen other not. So it's not as consistent as IVIG, and I don't really understand what's behind it. There's many different theories regarding the maturation of the B cells, the duration of the disease, the penetration of the rituximab into the ganglias, and so forth, the lymph nodes and so forth. So there's a lot of things that go on. But usually what I tell people, if IVIG is working for you, it's just, and you're tolerating well, no issues, I would just stick with it for now until we have a little bit more evidence. Because as you just said, people can, if they can go off on IVIG and they have a relapse, they may occur, unfortunately, permanent damage that may not come back. So I try to be a little bit more on the conservative side, and I only use rituximab if people have contraindication to IVIG or some other reasons.
Okay. Yeah. Thank you.
You're welcome.
Yeah, Martin, and just just to add to that, and not really additional information other than to say that I'm in the same boat as you are in terms of responding really well to IVIG, and I get infused every 3 weeks. And I often think, oh, like you, could I stretch that out to every 4, every 5 weeks? And I kind of share those same fears of, well, if I do and the symptoms return, is that relapse going to be permanent? And yeah, and I guess I've kind of netted out where you are, where 2 days every 3 weeks is a small price to pay for getting my life back. So that's kind of where I'm at. But yeah, I do just want to say I kind of commiserate with you and share with that struggle as to kind of what is the best schedule for me and my lifestyle.
So Richard, can I add to this? So, you know, I've had some people who go on 1 day every 2 weeks, and they found that it's better for them because then they can, and then, I don't know how off-label can we be, but I've had a few patients switch to subcutaneous IG,
Yeah.
which they found much more convenient for them because they do it on their own now. And I have several patients who does that, and they're happy with it. But obviously, that's going to be a little bit off-label, and you have to
Yeah, no,
figure out
there's
how to do it.
no compliance here, so we can talk about those things. Yeah, and that why before we get back to the audience questions, I mean, can you just talk a little bit about sub-Q and kind of how you as a clinician make that decision or help your patients in that decision-making process?
Yeah, so there's a few reasons why I suggest sub-Q to my patients. So sub-Q IG is exactly what you're getting. It's the IVIG, but instead of getting it in the vein, you're going to get it under the skin. So obviously, because it's a large volume, you cannot get the whole thing under the skin in one infusion unless you are doing a few tricks, which mean you are injecting a drug that makes space, and there's a product like that. The Takeda has one. Or if you do it a more concentrated form of IVIG and you do it more frequently, that's the another company that's CSL Behring that has Hizentra that does that. And then there are other options with 10%, but then the volume will be bigger. But basically, one of the main reasons I suggested for patients is then when they run out of veins. So the issue with MMN, it's a chronic disease. Most people go on for the rest of their life with it. And when you're accessing your veins constantly, at some point you run out basically of veins to access. So you are in a situation where you can either put a port, in your chest, and they can access and do the infusion. That's fine. Or you can just do subcutaneous. So put the IG under your skin, usually in the belly or in the thigh, and that could be another option. So a lot of my patients, before they go to the port, because it's more of an invasive procedure and there's a risk of infection or clotting of the port, etc., they would go to the subcutaneous version. Now, other reasons to try subcutaneous is that if patients have a lot of headache and nausea with IVIG, then having a smaller volume with the subcutaneous can sometimes help with those symptoms. Some people who travel a lot or who find it inconvenient to have sit the whole day for the IVIG, they do switch to subcutaneous IG. So these are some of the main reasons why people may want to switch to subcutaneous version of IG.
Yeah, and it's great that there's another option out there, and not necessarily a different mechanism of action or class of therapy, but different administration options, at least for now.
Now, I do have to say a disclaimer is that in the United States, I don't know if we have a lot of people from the United States listening, subcutaneous IG is not approved by the FDA for MMN, so it's going to be kind of off-label, or you gotta have to try to reason a little bit with the insurance, to kind of try to get it approved.
Yeah, absolutely. And I'll put a plug in for our health navigator here at the foundation, that if any patients in any of our disease areas are having issues with their insurance, we have a health navigator on staff who can help them navigate some of those issues. But back to questions from the audience. Actually, the first one that came in is from somebody who has identified themselves as owner. If so, they do have a very good question, so we'll open the floor up to them.
Oh, hi, this is Paul. Hey,
Oh, hey, Paul.
sorry, I didn't realize it was owner. But in any event, the question is about sort of the long-term optimal dosage of the immunoglobulin dosage. And so, the standard recommendation, as I understand it, is 2.0, I guess, grams per kilogram of weight for the loading dose, going down to 1.0 every, say, 4 months, as we just talked about. But a lot of people are doing 1.5 or 2.0 on an ongoing basis. And for a lot of the same reasons that everyone has mentioned, because it's been effective. For a patient who has seen a good result from 1.5 or higher, is it fine just to go on an ongoing basis at that higher level? Is there any reason not to? Because as people have mentioned, there's always the concern that if you drop it, would there be a recurrence? Or is it strongly advised to try to drop down to the 1.0 level because of potential, I guess, long-term negative impact of the treatments? Would love your perspective on that.
Yeah, that's a great question. So you're totally correct. When we start people on IVIG, we typically recommend 2 gram per kilogram loading dose or induction, and then we follow by 1 gram per kilogram every 3 weeks. This is the most commonly used way of administering IVIG. Now, some centers do 2 gram per kilogram and then repeat another 2 gram per kilogram 4 weeks later. So there's a lot of variability depending on, but I think if you look at most experts, this is what they do. And for the main reason that this is how it was studied back in a large trial on CIDP almost 20 years ago now. Now, that being said, we know that not everybody needs that dose of IVIG. Some people need more, some people need less. And unfortunately, the only way to tell is by trial and error. So what I tell people is that let's try to get you to what we think is going to be your maximum improvement. Okay, so let's say you start people on IVIG, they get better, and they, ideally they don't have any deficits, but unfortunately, a lot of times there's some deficit that remains. But when we feel that this is the best you're going to get, we start playing around by reducing the dose. If we feel that, hey, this improvement is not enough, then we actually increase the dose. And another thing with MMN is that what we've noticed is that there is a significant number of patients that over time seem to kind of lose the optimal response, if you want, to IVIG. So they have to go up on a higher dose. I have patients who are getting 2 gram per kilogram every 3 weeks, and they need it, if they, or I have some patients who have to get it every 2 weeks because by the 3rd week, they actually have the weakness comes back. So each individual is going to be very different, and it's not a good thing to just stay on the 1 gram per kilogram for the rest of your life, say this is what it is. You really have to change the dose and try to find the least amount, obviously, you need to maintain a decent strength or as normal as you can be. Now, that being said, obviously there are potential adverse event that you may want to look for. The less serious ones are maybe the nausea and the headache, etc. The more serious one are the potential of having a blood clot, especially if people increase the infusion. They get impatient, the nurse get impatient, or the patient get impatient, and they increase the infusion rate because they're like, well, we're tolerating well. The problem is that if you do the infusion rate very quickly, then you are at the risk of having more blood clots, which is something that could be serious because if the blood clots usually starts in the leg and move to the lungs, that's a pulmonary embolism, or if you get a blood clot in the brain, that's a stroke. So I think that's a downside of trying very high dose and trying to do it very quickly. But at the end of the day, if you're doing things the right way, you're not doing the infusion rate very quickly, even if you're going on a higher dose, most people do well with that. And again, it's going to depend on the patient what their ideal dose of IVIG is.
Great, thank you.
Paul,
and while we're on the topic,
yes, that was very helpful. And it sounds like it's really not so much the dosage level, but the rate of transfusion. That is the big risk factor. And then if you do it over a longer period of time, I guess 2 days,
Yeah.
that helps, right?
Right. And if you split it, if you, let's say you do it every 2 weeks, especially if you're getting to a high dose, you may actually use a lower dose more frequently. So let's say you're at 2 gram per kilogram every 3 weeks. You may go down to 1 gram per kilogram every 2 weeks, which technically is a smaller dose, but it may give you even better control of your disease.
Got it. Thank you.
Thanks, Paul, and thanks, Dr. Karam. And while we're on the subject of dosing, might be a good chance to give Jeff Oberlees a chance to ask his question with a very specific dosing question. Jeff?
I think he sort of just answered it. I guess my concern is there just a risk of too much IVIG over time? I think my dosage is fine, but
Yeah. Over time, I don't think there's, at the end of the day, it's not something that is going to build up in your body because your body's going to get rid of it, within 3 to 4 weeks. So nothing's going to build up over time. That needs to be worried about, in my opinion.
thank you.
All right. Great. And John Devereaux, you've been waiting very patiently. I'll give you the floor now.
Good morning or afternoon, wherever you are. So again, there's some parallels to a lot of the questions being asked. So I've been on an IVIG treatment for 5 or 6 years now, and it's been, I'll call it effective. But a year ago when I visited my neurologist, he said, okay, if I saw you today, I wouldn't detect any real symptoms. So effective in that sense. And then the last trip, he identified some new weakness in a new place. So I was left hand issues, left foot issues. And then the most recent visit, he identified some weakness in the right hand, did the electric tests and found some blockage there and said, okay, you've got new symptoms manifesting themselves here. And it's a little troubling because I've been on a pretty regular treatment that, like I said, has been effective. How common is it? Does efficacy get reduced over time, or just some physiological changes? Why, how common is it for new issues to emerge even though treatment is being given?
Yeah, well, John, I'm sorry you have new weakness despite being on treatment.
Sorry. And I'll just comment.
So,
and so as a result of this test, he decided, let's do sort of a new initial round of treatment. So instead of doing, once a month, a 2-day sequence, we're going to, for the next 3 months, do a 4-day treatment, sort of the double dose to start me off again for at least the next 3 months. So.
Yeah, I think that's reasonable. I think your question is, how often does that happen? And, unfortunately, it does happen, more than we like it to happen, because what we, again, experience with people with MMN is that for some reason, some patients over time do seem to kind of lose the efficacy of the IVIG, and they seem to have to require increased dosage. So, and some other, are lucky and they're just do fine with the same dose for decades. So we don't really have a way to predict that, but I'm glad that your neurologist picked it up and was able to increase the treatment. And I'm hoping that with that increase in the IVIG, you will get better, and then perhaps maybe they can lower the dose or do it maybe like every 3 weeks instead of every 4 weeks, 1 gram per kilogram. Because obviously 2 gram per kilogram is a larger dose, going to take 4 days of your time, which is not very convenient.
Very good. Okay, thank you. I appreciate the insight.
You're welcome.
We have a couple more questions in the queue, Chafic, but I do want to just pause here and kind of give you an opportunity to transition a bit to research and talk a little bit about what's going on in research in MMN and what are some of the potential new therapies that you're excited about.
Yeah, I mean, we're really excited because we are in an era where there's a lot of advancement in neuromuscular disease, especially in CIDP, Guillain-Barré syndrome, and MMN. So, and as we've witnessed now, some people are having some challenges with their current treatments, right? So having an alternative options to IVIG is going to be a great welcome. And I think we're getting there. So there's a different approach to autoimmune disease. If you think about it, the immune system is made of, what we call the B cells and the T cells. But there's also another one that a lot of time we don't mention it very frequently. It's called the complement system. And the complement system plays a very important role in inflammation, in recruiting these autoimmune cells, and in ultimately destroying their target. So they actually can destroy the nerve when they're activated. So the good news is that we do have a very promising approach to MMN, which is blocking the complement system. And there's at least 2 companies that I know of that are actively studying this, and some are in phase 3, which, if you think about it, phase 3 is really the ultimate or the last step in clinical trial where you get drugs approved by the FDA. So we're not really talking here, 10 years from now. We're really talking, maybe one is maybe too optimistic, but a couple of years we will have, hopefully, and I suspect that it will be, it will happen, a new treatment for MMN. One, it's going to be a much quicker infusion. So the infusion, at least for the most advanced drug that is being studied, called empasiprubart, is a less than an hour, like an hour or less infusion. So imagine that compared to IVIG. Now, that being said, there may be even, they're comparing the company, what they're doing head to head with IVIG. So we're also going to know if it's the same efficacy of IVIG, which to me will be great because it will be an alternative option and quicker.
Absolutely.
But also, would it be even better than IVIG, meaning that people who we thought that this is the best they're going to get with their dose of IVIG because they have some residual weakness, but with the new drug, they could perhaps gain even more. So this is really exciting time for us and for our patients. I mean, for us too, because we do want to have more options. So it's a great thing, and hopefully, knock on wood, things will move the way we're expecting them to move, and in a couple of years, we'll have new treatments for MMN.
Yeah, no, it is a super exciting time. And if you just think about some of the issues we've heard from patients here on the call in the past half an hour in terms of infusion times and high doses and the effects of IVIG maybe wearing off over time and recurrence of symptoms. That's not to say that these new therapies are going to solve for everything, but it's just exciting, as you said, that clinicians and patients are going to potentially have more options. So exciting times indeed. And I'll open up the floor to Brad, who does have a specific question about one of those clinical trial programs that you mentioned. Brad?
Hey, how are you? Nice to meet everyone. So I've been diagnosed with MMN for several years and been on the IVIG pretty consistently for the past 3 to 5 years, and it's done absolutely nothing. In fact, per my last EMG, it's my results have gone down. So I was just recently accepted into a clinical trial with University of Texas. They're running it here and sponsored by Dianthus Therapeutic. Wondering if you've heard about this and any thoughts?
Yeah, so the Dianthus is another complement inhibition approach. And well, first, I have to say I'm sorry that you didn't respond to IVIG and your situation is declining. But the complement system is very promising. I mean, we've seen people have better response with it, what they had with IVIG. Obviously, as I mentioned before, if people don't respond to IVIG, you have to make sure that the diagnosis is correct. But assuming your diagnosis is correct, I'm glad that you got into the clinical trial. and I hope that you will benefit from it. I think that it is very promising then, and hopefully you'll have a good response.
So you have heard of this then, and you're
Yes. Yeah,
okay.
Dianthus and Argenx are the two companies developing complement that I'm aware of for treatment of MMN.
Okay. So other than IVIG and this clinical trial, is there? I mean, I was definitely diagnosed. I mean, it went through a whole international board of reviewers to even
Okay.
get into the trial. So they're confident in their letting me in. So this, I mean, is it worth me even continuing with IVIG? I mean, the best my doctor can say is, "Oh, well, you're not getting any worse, right?" Well, that's not the truth anymore, you
No.
know? So
Yeah.
what do you do?
Well, if you're in the clinical trial, then they will tell you what to do because you're gonna probably be on one or the other, right? So,
Right.
but we wouldn't know what you're on.
Okay.
Now, obviously, the question is, well, what if the clinical trial does not help you, or you want to explore other options? Then
Mm.
we do have alternative options. It's going to be off-label, and there's no guarantee that's going to work. But there are other options that you could explore with your neurologist as well.
Okay. All right. Thank you very much.
You're welcome.
And Dr. Karam, just while we're on the topic of complement inhibition, our friend Martin weighed in with a question in the chat. What are the risks of effectively suppressing the complement system? So are there these new therapies sound very promising, but are there risks associated with them?
Yeah, so obviously the complement system is an important part of the immune system and it helps fight bacterial infections. So there is a potential high risk of being infected. Actually, specifically for complement inhibition, we do recommend vaccination for several bacteria, but more specifically for Neisseria meningitis, which is a kind of could lead to inflammation in the brain, infection in the brain, which is a serious problem. So everybody who's entering these trials are getting vaccinated. So far, we have not seen any specific serious signal from the phase 2 study, at least. Phase 3 has larger number of patients, so the more we're going to treat patients, the more of these adverse events may arise. But so far, things look relatively safe. So the amount of infection, etc. And we've used complement for other condition, by the way. So myasthenia gravis, we've been using complement for, I would say almost 10 years, if not longer. And there is a risk of higher infection, but it is kind of a small risk. So anything, unfortunately, we're going to do, there's going to be a risk with any medication we're going to get. But measuring the risk-benefit ratio is important, and it seems that it's worth it in these medication for at least for now.
Okay, great. Thank you. And Regina, I'll give the floor to her. She has a question about alternative therapies.
Hi, thank you so much, Dr. Karam and Richard, for doing this. I have had the IVIG treatment for 10 years. This May will be my anniversary. Been very effective. And there's so many alternative therapies. There's a lot of noise out there as well. Electroacupuncture, they're trying to do hybrids and fusions of these alternative therapies. And while I did try physical therapy, I injured myself. I overdid it with the weights and the rubber bands and the clay, you know. So I'm not doing physical therapy anymore. I'm just going to continue doing my own exercises because most of it is my right side of my body, my fine motor skills. But for 10 years, I'm able to build my strength, my muscles with weight training. So obviously, you have the cannabis market, there's medicinal cannabis, and then there's these acupuncturists that say, we can cure everything. Is there any efficacy or evidence on any alternative therapies that you've seen in any kind of medical publications? I'd love to hear your opinion.
Yeah, that's a great question. So obviously, we all would like to have something alternative that is more natural, etc., that can help. But the truth of the matter is that there's no evidence whatsoever that anything specific could help with MMN, unfortunately. That being said, exercising, maintaining, strengthening without injuring yourself. So I'm sorry you injured yourself with physical therapy, but that's usually the right way to go. So I tell people, lead a healthy lifestyle. It's just common sense. Stay away from very processed food, from fried food. Try not to get diabetes, because if you have diabetes, that puts you at risk of developing neuropathy on top of that. So, stay fit, get your labs done with your doctor, and if you have diabetes, treat it, and so forth. And lead a healthy lifestyle. But I try to discourage them from trying supplements that are not proven. They're not really controlled, by the way, these supplements. We don't know what's in them. They could be something said that this is what you get, but nobody's really testing these supplements to make sure that there's nothing like lead or anything that is toxic to you that's in them. In regarding to acupuncture, we know that acupuncture can help with certain types of pain, but it does not help with nerve regeneration or with autoimmune diseases from what I'm aware of. So if you're in pain and acupuncture helps you, that's great, or massage therapy, or warm and heat or cold alternating helps. But I don't expect those to replace, unfortunately, the current treatment that we have for MMN.
Well, thank you so much. I have reduced my sugar significantly. They say that's, an anti-inflammatory diet is recommended. My naturopath, who has a PhD in biochemistry, wants me to be on a carnivorous diet because he thinks the protein will be synthesized better for my muscles. So you have all these opinions, and everyone's extreme. So I'm integrating some of what he said, but not all of it. It's too
Yeah.
radical.
You're right. So being extreme is never good. So being
Right.
more balanced and having a moderate approach, eating your vegetables, eating your fibers, eating your fruits, eating some meat, eating some chicken, with everything with moderation is the right way to go.
Yeah, I think that's sage advice. And Laurie Howard also has a question on physical therapy. Laurie?
Hi, well, I'm a newbie.
Welcome.
Not exactly. I lost feeling in my feet April of 2017. I went to 10 neurologists who said there's nothing wrong. And I go, yes, there is. It got worse and worse. I finally found someone and I just started IVIG for the last 4 months. And now I'm off because I had my tests actually last week. I really have improved a lot. But I've been doing physical therapy, but they were also very dubious. They go, well, what do you mean? What is this you have? No one understands it. But I do think I have to retrain my brain and how to walk again because, it was 7 years where, my gait is totally different. I want to get back to where I was. I just wondered, what does one say to a physical therapist? I mean, because they know nothing about it. I wish they did know more about it. I think more people have this than we know. And my other question is this by any chance genetic? Do they know? Is anyone studying that?
So two very good questions, and I'm glad you asked it, because for your first question, we as physicians and patients, this is our job, is to educate our colleagues and our providers about this disease. So yes, you don't know it, but if you taught your physical therapist about what it is and they get another patient, then you've helped your fellow patients as well. So that's a great thing. Obviously, if people don't want to learn and you're like at a roadblock and you feel that you're not getting the help you need, you may want to, ask for a different opinion with a physical therapist and so forth. So that's number one. For your second questions, this is not a genetic condition, so you're not going to pass it to your, family member, your offsprings, etc. So that's my answer to the questions.
Okay. Dr. Crum, we're right up against the hour. We do have one more question. Are you able to hang in for one more?
Yes,
Or
let's make our yeah, I'll make the next meeting wait 1 minute. That's okay.
thank you very much. Great. Chris Betts, I'll give the floor to you, Chris.
Hey, thank you. Since we're running out of time, I've just typed in that I have an MMN for about 4 years, been on IVIG, and have been mostly stable. And right now, my dosage got increased about 6 months ago to 75 milligrams weekly, and I seem to have some improvement. A year and a half ago, I went off IVIG to try Vyvgart Hytrulo and immediately went downhill significantly and quickly. So my conclusion from that is I'm very dependent on IVIG. And then I'm getting to is that with the trials going on, being double blind and so forth, I may not receive my current IVIG during the study. How do I know or get comfortable that the trial medicine will at least prevent any additional decline? Because I just can't risk another setback.
Yeah, I mean that's the risk with clinical trials. That anytime you get into clinical trial, you don't know what you're getting into. Obviously, Vyvgart does not work for MMN for many reasons. One, we think MMN is driven by IgM antibodies, whereas Vyvgart only works on IgG antibodies. So I would not try it. But for the complement, I think the data looks from the phase 2 studies look very encouraging. So I would not be very concerned, but at the same time, it is a risk you're taking. So what I tell people, if you don't feel comfortable, don't do it. Don't do the clinical trial. You have to be really comfortable to do a clinical trial. If you're not convinced, then it's not for you, and just wait until the drugs get approved, and then you can try it commercially. So it's your choice, remember, and you can decide to do it or not.
Awesome. Thank you, Dr. Crum. I appreciate you sticking around for a couple of extra minutes, and a huge thank you. This has been great. I always find your talks very educational and take a lot of nuggets away from them. I think it's great to hear from other patients too. We need to be here for each other, support each other, and just hearing tidbits of other people's stories is great as well. So, thank you, Dr. Karam. Thank you to everybody who joined today. For those who have some more questions, please check out the Foundation's website for all the tools and the resources that we have to support the MMN patient community. Also, if you are in a position to do so, please consider donating to the Foundation. We depend on support not only from our sponsors here, but also from individuals like yourself to keep providing this kind of great programming. So again, thank you to everybody for joining today. Have a great rest of MMN Awareness Month, and we'll see you next time. Thank you.